No problem. Thank you so much for the invitation. I'm honored to be here today to speak to your audience about the utilization of MRI in the characterization of knee, especially in the setting of sports injury. I'm an MSK interventional radiologist in Orlando, Florida, at Advent Health. My pleasure to be here. So let's begin. So we're first going to sort of work ourselves from the outside towards the inside of the knee. Looking at the collateral ligaments first. So one of the weakest primary knee stabilizers is the medial collateral ligament, which is the most frequently injured ligament in the knee. Usually this injury occurs with valgus stress to a flex knee, like here, football player coming on the side of the player and impacting the lateral aspect of the knee, opening the medial aspect of the knee with direct force. The role of the MRI is to evaluate for concomitant injuries. Usually, non-operative management, the physicians are able to obtain excellent results. The medial collateral compartment, the anatomy consists of 3 different layers. The layer 1 is the most superficial crural fascia overlying the medial collateral ligament. Layer number 2 are the superficial tibial collateral ligament band. And the deep layer consists of the meniscofemoral ligament, which is this one here, and the meniscotibial ligament. So 3 layers constitute the anatomy of the medial collateral ligament. In terms of injury, what we call grade 1, it's basically a micro tear or expression injury. The integrity of the ligament is preserved, and this is a stable injury. Usually, we see that with periligamentous edema superficial to the layers of the MCL. Grade 2 is a partial tear or rupture. Usually, is during the clinical examination, it's painful to stress, and there might be some detectable laxity. Grade 3 is a complete dissociation, complete tear, leading to instability and laxity. So, how does that look on the MRI? Here's an example of grade 1. You can see there's a little bit of periligamentous edema right here, deep and superficial to the MCL. And you can see how the layer number 2, right, this superficial and even the deep fibers here, layer number 3 is intact. All you see is just edema superficial to intact ligament fibers right there, and here as well. So grade 2 is actually a tear, right? So perhaps the difficulty that I have sometimes with grade 2 injury is that we cannot grade grade 2, right? We cannot say it's a high grade grade 2 or low grade grade 2. It's just basically all those injuries are put in that bucket of grade 2. So here you have an intrasubstance tear. So the constitution of the ligament is violated, and you have extensive deep and superficial edema to those ligaments. So this will be a grade 2 injury or sprain. And then a grade 3 will basically be a complete rupture, complete full thickness tear of the ligament. So you have 3 different injury levels here. So here you have proximally at the level of the femoral condyle attachment. You have a mid-level injury here at the level of the joint line or meniscus, and then distally at the attachment, near the attachment of the tibia. That's the injury here. So basically, usually you have in terms of frequency, the more proximal injuries occur more frequently than distal injuries, and they are managed differently. So differential diagnosis, when you see edema in the medial collateral ligament compartment, you can have an MCL injury, you can have edema from a ruptured brachial cyst, you can have degenerative changes. You can have medial meniscal tear with extrusion that will give you edema in that compartment. You can have bursitis within the MCL or the pesant serine bursitis. And you can have also edema tracking from the medial patellofemoral ligament injury tracking down inferiorly onto the region of the MCL. So these are mimickers. Here we have extensive edema, right, on the medial compartment. Here's the MCL. And you can see edema superficial and deep. This is another MCL mimicker. You have here extensive peripheral occlusion of the medial meniscal body, tenting, right, causing pressure on that MCL, which over time will lead to ligamentous inflammation, basically periligamentous edema deep and superficial to that MCL. So this is another, in addition to that, you also have complete cartilage loss in that medial compartment with severe knee OA. But an extruded meniscus can give you ligamentous inflammatory changes mimicking MCL injury. This is another MCL mimicker. So you have a flap tear on the surface oblique tear here with a flipped meniscal fragment right there into the meniscal tibial recess. That, the pressure and the abnormal biomechanics will give you that periligamentous edema that can mimic an injury. So here's another one. You basically have a dislocation of the patella here, and consequentially you have injury of the MPFL, the medial patellofemoral ligament, and that edema basically just trickles down onto the superficial to the MCL, mimicking MCL injury. So this is a transient lateral patellar dislocation with injury of the MPFL, and then consequential edema that tracks superficial to the medial collateral ligament. Something that we have to be aware of, many of us read X-rays, is the Pellegrini striatal lesion, which is basically a focal calcification in the proximal fibers of the MCL that will basically tell us that this is a chronic injury of the proximal fibers of the MCL, right there. Yeah. This is so there's something called an unhappy triad. So we can have isolated MCL injury, but we can also have concomitant injuries that can affect the medial meniscus and the ACL, the cruciate ligaments. So here we have an MCL injury, right? We have superficial edema to an intact MCL fibers, and then here we can see complete violation of disruption of the ACL, anterior cruciate ligament. So this is a complete ACL tear with an MCL injury, and in addition to that, we also have a ramp lesion, which is a longitudinal peripheral meniscal capsular tear of the medial meniscus, the posterior horn of the medial meniscus. So when you have this constitution of injuries together, that's usually referred to as an unhappy triad: ACL, MCL, and medial meniscus injury. All right, so studies have been performed that if you have concomitant bone contusions, what's the incidence of MCL injury? So, for example, here we have on the lateral femoral condyle, we have an area of barrel edema here, and you can see how this is a valgus stress, right? And you can see on the opposite side, along the proximal fibers of the MCL, you see periligamentous edema there. So this is from a lateral contusion, an impaction injury. And in addition to that, you can also have just direct contusion right there into the medial femoral condyle, violating the ligamentous, the meniscofemoral avulsion, and violating the ligamentous integrity there. So either you can have, just a contusion on the opposite side, right? Because you have a force coming this way that will open up the medial aspect of the knee, consequentially leading to MCL injury. Or you can have a medial contusion, just microwave avulsion with direct contact into the MCL, leading to various degrees of MCL injury. So MCL injury usually healed very well. For example, this is an MCL, a proximal MCL injury, high grade, grade 2, right? High grade partial thickness sprain that will over time lead to complete resolution of those edema and trauma, basically to the ligament. This is an avulsive fragment that came off the medial aspect of the medial femoral condyle. And you can see, consequentially, this is an unhappy triad, right? You can have avulsive ACL injury at the tibial attachment. Here's the MRI equivalent of this image. You can see the small bony fragment of the adjacent medial femoral condyle with extensive edema in the bone and the adjacent soft tissues, and then the ACL complete avulsion of the tibial attachment. So an X-ray can tell you quite a bit of information if you're paying attention to those details. And this is how it was fixed. So here's a single orthopedic screw fixating that displaced medial femoral condyle fragment. And this is an additional screw, basically taking care of the attachment onto the tibial platform, tibial eminence, I'm sorry, of the ACL attachment right there. So MCL bursitis, right? You may see that at times. What is that? MCL bursitis is basically fluid that you have between the deep and superficial layers of the MCL, right? Separating that space. So basically, you will have fluid right here, and then this is the superficial layers of the MCL, and these are the deep layers of the MCL. So when you have fluid within that space, that's referred to as MCL bursitis, right there. So it's, fluid between the deep and superficial layers. Usually it's continuous, when you continue down into the distal aspect of that compartment, that can continue on with the pes and bursa, which you can see down here. All right. So moving on to a different concept, posterior medial corner of the knee. This is sometimes referred to as the hidden or forgotten corner of the knee. Not a lot of people speak to. A lot of people just focus on the posterior lateral corner of the knee and forget that there is a posterior medial corner of the knee, and it's highly relevant. So here's a lateral aspect of a knee here going on the sagittal T2 images. A lateral medial used to show you the different anatomic configuration of those two compartments. So the posterior medial corner of the knee is a quite complex system of static and dynamic stabilizers. The reason why it's more commonly injured is because there is a tighter anatomic relationship and injuries can often involve the resin of the meniscus, the meniscal capsular ligaments, or even the tendons that stabilize that compartment. And this is a frequent cause of chronic medial knee pain. If I can move forward. Okay, so here we have just, from different articles, the representation of how complex the anatomy is along the posterior medial corner of the knee. So you have the semimembranosus tendon, which is considered to be the main stabilizer in that region with different arms. You can see a capsular arm here that projects into the femoral condyle posteriorly, and then you have different components extending into the tibia as well. The tibial collateral ligament, right, or the MCL, that's another portion, component of this corner. You have basically the different arms of the semimembranosus extending down into the tibia, and you have different ligaments. We're going to go over that on the next slide. You have the oblique palatal ligament, more posteriorly, and you have the posterior oblique ligament, posterior medially turning into the medial aspect of the knee. So this is just to show you how complex the semimembranosus tendon anatomy is. So here you have basically the the tendon coming down. You can see how you have different arms, right, of the semimembranosus tendon right there extending into the femoral condyle, but then you have inferiorly into the capsule as well. Enumerated here 1, 2, 3, and 4. It's quite complex, the anatomy in that area. So I just want to show you, basically, this is a schematic representation of that. On the axial plane, you have the OPL, which is one of those ligaments that we spoke of. And then oblique palatal ligament, you have the posterior oblique ligament, which turns basically posterior medially into the MCL. This is a semimembranosus going down and attaching onto that area there, and then the respective overlying. So just to show you again, here's the MCL, right? The deep and superficial layer of the MCL. And then we are going to, this is the PD non-facet view on the sagittal plane, showing basically the attachment posterior medially at the superior margin here of the femoral condyle. And you have basically more inferiorly some of those attachments of the semimembranosus that we discussed. This is how it looks on MRI. And here on the axial plane, you have basically the semimembranosus tendon coming down and attaching onto those areas there. And this is the medial head of the gastrocnemius. This is a space that we refer to as the Baker's cyst or palatal bursa, posteriorly in the knee. Here's the semimembranosus coming down. You can actually see how wide the attachment is of that semimembranosus tendon. This is semimembranosus tendon is usually not looked at by many radiologists. They sort of don't think that this is, the tendon plays an important role in stabilizing the knee in that component. encourage you to take a look at that area just to make sure that you're examining the MRI properly. Sorry about that. This is another case here where you can have an impaction contusion here along the medial and posterior aspect of the medial femoral condyle. You can see how that ligament, right? That here's a medial heterogastrocnemius, here's the membranosus, but that ligament that we spoke of, the OPL, is completely violated, right? You don't see continuity of the fibers anymore, and you see edema in its place. So this is a posterior medial corner injury. He is basically a continuation of that injury more inferiorly. You can see how that ligament is completely obliterated with the underlying contusion of the bone there. So now on the coronal plane, we can see how the MCL is partially torn. This is a grade 2 sprain with a contusion injury in the adjacent bone. So here, this is a more extensive injury. Right now, you have those ligaments completely torn, basically the OPL and the POL. You can see how the posterior aspect of the medial femoral condyle here, the ligament there, the capsular ligament is completely violated, right? It's not defined anymore how it used to, how it's supposed to be. So it's supposed to be basically like this here, that dark band of tissue back here, but in its place you have edema, you have basically hemorrhage within the ligaments with torn fibers, giving you this appearance. So this will be basically posterior medial corner injury. And then on that coronal plane, you see how there's MCL bursitis, right? A fluid between the deep and superficial layers of the MCL more anteriorly. Here's another case of that contusion, violation of the capsular ligaments posterior medially. And here, right, we always look back here at the superior attachment of the posterior superior attachment of the medial. Sometimes you'll see that usually the fluid will be between the semimembranosus and the medial head of the gastrocnemius, and the fluid can track superiorly and inferiorly by a few centimeters, like this here. Here's the posterior medial attachment of that capsule that I encourage you to look at as well as you evaluate you MRIs for knee injury in this compartment. So this is an MRI of an NFL football player here in the United States, a wide receiver, 24 hours after experiencing a twisting injury with posterior medial pain, but a negative McMurray's test, right? So clinically, he had no medial meniscal injury, but he was quite tender posterior medially. So what do we see here? We see basically a meniscal capsular injury, longitudinal vertical tear at the posterior horn of the medial meniscus, and we're just going to run this MRI. Basically, here's the contusion, here's the violation, right? This is supposed to be all dark, right? You're not supposed to have any bright signal here. If you do, that's abnormal. You can see here more injury, as we go more medially with the contusion there. So this is a posterior medial corner sprain, because you're not only violating the most posterior aspect of the meniscus, you're also violating the capsular attachment onto that meniscus, the OPL and the POL ligaments that we spoke of. So this is a posterior medial corner injury, but without a meniscal tear per se. Symptoms and MRI findings usually resolved with conservative treatment. This is an 18-year-old soccer player with a positive McMurray's sign. So what do we have here? We have the obvious tear posteriorly separating the capsule from the posterior aspect of the meniscus. And then here, the meniscus, the superficial, the red zone, meniscal zone of the meniscus is violated and torn. And here's another oblique tear along the undersurface of that meniscus, the posterior horn of the medial meniscus. So this is basically the peripheral meniscal tear. You can see how irregular that junction is there. So this is something that we will call posterior medial corner injury with injury of the posterior horn of the medial meniscus. This person went on to have meniscal repair with suturing. So here's another example of the posterior medial corner of the knee. And just, you can see how there's asymmetric, intimate posterior medial meniscal capsular relationship. Let's just go back there one more time and show you that once again. Just bear with me here. So basically, this is the lateral aspect of the knee. Here's the medial aspect of the knee. We're going anterior to posterior. I just want to show you how intimate that relationship is posteriorly. And you can see back here, basically, how much. So here you have, on the lateral side, you have the meniscus in full profile. But here you can appreciate how the meniscus is intimately associated with the posterior medial meniscal capsular anatomy, and hence a lot more injury happening in that compartment compared to the contralateral lateral side. So basically, this is just to show you how here's the meniscus sort of fused, right? Kind of like attaches itself onto the posterior medial capsule, and hence that tighter relationship leads to more injury. So here's another example. Sometimes these injuries can be very, not too dramatic or not too, so almost like very, very small in detail. So you always look at the anatomy here. This is an example of a meniscal capsular separation due to a tear in the superior oblique meniscal capsular ligament. So you can have an isolated injury as well. So meniscal capsular separation, that's a term that a lot of people use here in the United States. Sometimes it can be confusing because it could reflect other etiologies such as peripheral meniscal tear. It could reflect meniscal capsular ligament injury. It could reflect bursitis. Likely was created due to a poor MRI resolution in the past. And then what I always recommend is that for you to describe the pathology, right? So if you have violation of the meniscal capsular junction, for you to detail exactly where the injury is and if there's any involvement of the most posterior aspect of the medial meniscus. So here's another case. What we have here is basically an MCL bursitis, superficial to the fibers, that continues inferiorly as a Penson serrane bursitis. So basically, I just want to show you one more case of that, just to show you that there are different etiologies that can look like a posterior medial corner injury. So conclusions, right? If you want to take a pause, information that I'm giving you right now. So conclusion 2022, the posterior medial corner of the knee is a quite complex and diverse group of injuries, as you saw. Try to discriminate the peripheral meniscal tears from the meniscal capsular ligament injuries. Try to be specific, right? Say for this most posteriorly, it's probably involving the ligaments. If it's a little more anteriorly involving that peripheral aspect of the medial meniscus, you want to be very descriptive how you describe that in your reports. Usually, don't use the term meniscal capsular separation without explanation, right? What is actually torn? There's edema extending into this compartment, that compartment, superiorly, inferiorly. Just be very specific how you describe that. So moving on to the lateral collateral ligament complex, perhaps a better known player in the knee. So the different anatomic components of the lateral ligaments complex, we have the iliotibial band right here coming down, attaching onto the lateral tibial plateau. We have the lateral collateral ligament, or the fibulocollateral ligament, as some people refer to, and the bicep femoris tendon attachment. We also have other stabilizers in this region, such as the acral ligament, the popliteus tendon, the palliatiofibular ligament, the fibulofibular ligament. In the lateral collateral ligament complex is commonly associated with PCL injuries, unlike the MCL, often require reconstruction. So, and hence, how critical of a role we play when we describe these injuries on MRI. So this is an example of a complete fibulocollateral ligament tear or lateral collateral ligament tear. So here we have the normal anatomic course of the lateral collateral ligament. You can see right there, right? Just a few centimeters from the most proximal attachment, how the ligament is completely violated. There's a big gap here. In its place, you have fluid and edema in that region. So this is a really sometimes, T1 or PD Virasack can help you out. So if you see an area of thickening that is dark on T1, and T2 as well. That just basically means that this injury is old and it had resolved, but in its place you have thickening and fibrosis of that ligament. This is an example of biceps and fibulocollateral ligament tear. So basically you have the lateral collateral ligament and the fibulocollateral ligament coming down here and completely avulsed of a suspected attachment onto the fibular head. And then it's kind of hard to see here, but on the most sagittal view here, you see the biceps tendon completely torn and retracted. This person happened to have a PCL tear as well, an avulsive tear at the expected proximal femoral attachment. So you probably have seen this on X-rays in the past, the fibular avulsion, right, where the initially. Here's another fracture that you see in this compartment called the C-Gan fracture. So the C-Gan fracture is basically a bony avulsive injury that happens off the lateral margin of the lateral tibial plateau. So this is an X-ray representation of that injury. And then this is the follow-up MRI. You can see the actual bony fragment coming off. All right, so the lateral avulsive injury, and this is a lot of people. There's a lot of controversy in the literature. What does actually the C-Gan fracture represent? So the most accepted theory is that basically this is an injury to the anterior band of the fibulocollateral ligament. So the lateral collateral ligament sends a little band that attaches there, and then when that avulses, you see the bony fragment and the MRI findings as well. So one thing that usually is tested here in the United States for residents and fellows is that a C-Gan fracture has a 90% association with ACL tear. So if you see this on X-ray, you ought to recommend an MRI just to assess for concomitant ACL tear that is highly associated with this injury. Highly associated with the injury. This patient also happened to have an MCL proximal tear here on the MRI that he had done. So here's the the T1. You can see basically edema, right? And you just basically add some more information to that injury. Here's his complete dissociation of the proximal MCL with hemorrhage in that region there. He said C-Gan avulsive fracture. All right, so moving on. So knee ligament injuries, or the incidence is about 100 to 100,000 patients a year. So I just basically enumerated here from top to bottom the most common injuries in the knee. So most commonly, as you would expect, is the ACL coming at 63%, followed by an MCL, 44%, followed by PCL, and followed by lateral collateral ligament. Usually 40, almost 50%, right? For just to simplify this statistical information, almost 50% of those injuries are isolated to the ACL. And almost 30% are isolated to the MCL. And then you have basically the concomitant injuries. So a quarter of those, so of that, or so 13%, you have ACL and MCL injuries together. And only 2%, when you have MCL injury, you also involve the posterior cruciate ligament. 60% of acute tears happen during pathologic motion and sports-related injuries. So it's important that you recognize these injuries and appropriately describe them in your reports. So what about ACL injuries? So its increasing incidence is probably related to the increasing sports participation that we see throughout the world, right? Usually related to twisting and jumping injuries, high energy activity level injury, sports related activities. Usually you have a sudden pain with an audible pop that leads to some disability. That's the most common descriptor when they come into our offices. The physical exam sometimes can be very difficult on the acute stage, just because they have a lot of pain and they tend to guard and prevent an appropriate physical exam. So in ACL injury, basically what happens is you usually have a pivot shift injury with reciprocal contusions, and this is called the terminal sulcus. It's the middle one half aspect of the lateral femoral condyle, and then usually what happens is you have a rotatory motion that contuses the posterior aspect of the lateral tibial plateau as well. So this is a classic pivot shift mechanism of injury, contusion that you'll see in MRI with ACL injuries. So that's pathognomonic for ACL injury. So usually, when we have ACL injuries, there's the rule of thirds. A third of them do well, a third of them give up activities altogether, and a third of them do very poorly. So in terms of meniscal pathology, 45% of them present in acute setting, 88% of them are present in the chronic setting, right? So usually in terms of medial meniscal tears versus lateral meniscal tears, most patients present with medial meniscal tears, but you can see how most patients present in the acute setting, in the chronic setting, rather than the acute setting, and that's the same for the lateral meniscus as well. Just remember that most patients will present with meniscal tears in the chronic setting, not in the acute setting. In terms of chondral defects, you will have 20% of the patients will present, with acute injury. This is in the setting of ACL injuries, and then most of them will present in the chronic setting, right? So that just tells you that that MRI plays a pivotal role in describing and helping our colleague surgeons to basically decipher different treatment for these patients. So usually the mechanism of injury that you see ACL tears are the pivot movement of the knee. So classically in the United States, you have the football player that is running, is twisting his body trying to catch a football coming, and the knee basically dislocates transiently and contuses those two compartments that we spoke of. Usually you have anterior transition of the tibia. It usually happens with the foot planted, with a directional change, right? So they have deceleration and rotational change, and hyperextension injuries are less commonly found mechanism of injury in ACL tears. Commonly happens, the way I see it in hyperextension injuries, you see it in the basketball setting or a skiing setting with high boots causing this type of injury, and dancers as well. All right, so basically here we have the pivot shift mechanism of injury, the classic bone contusion pattern in the setting of ACL injury. Basically, you have in addition to this, you can have a lot of meniscal tear because you have impaction of the posterior horn, right? These two compartments are coming together and grinding together. So that grinding mechanism can actually cause a lot of injury to the posterior horn, the lateral meniscus. You can actually see a completely absent meniscus here with displacement right there. So you have the bottom contusion, and then this is a displaced fragment here more peripherally that you don't see posteriorly on the sagittal view. All right, so the primary signs that you're looking for an ACL tear, and I would really want to drive this point home, is basically you're looking for this continuity of the ACL. Basically propagation of those fibers in the setting of tears. When you have these continuous fibers, usually happens in the mid substance more commonly, especially in skiers. And the second location is the proximal location. You will have edematous ACL, swollen ACL. Make sure that you can differentiate that from synovialization. Synovialization is a term that is used when you have mucoid degeneration and you have that thickening of the synovial lining of the ACL. And also make sure that you differentiate edematous ACL from ACL ganglion cysts that can occur in the setting of chronic injury. You can also follow the Blumenstadt line, right? And then see if the ACL perhaps has an abnormal contour. So this is how an acute ACL tear will look like. So basically what you're trying to do is you're trying to find the continuity of those fibers. Not only here, the fibers are swollen, they're thick, but you can see how here you have absent of normal ACL fibers. So that is a high, basically it's a partial thickness ACL tear. And you can see the concomitant extensive edema that you see in the posterior capsule here involving the ligaments, the respective synovial recesses. You can see also the concomitant suprapathology and effusion that you see in this case as well. So some people have said that it's almost like you take a scissor and you cut it, right? You can either cut it completely or partially, and hence you will describe if it's a partial tear or a full thickness tear. So this is basically an acute ACL tear. The empty Nash sign can help you. So usually The Nash is occupied by partially the PCL, but mostly by the ACL on the coronal view. You can see how there's completely absence of that here with a lot of extensive edema and the no fibers continually propagating from the tibia to the femoral condyle. So indirect signs of ACL injury, usually they do not improve diagnostic accuracy. They can be specific, but they're insensitive. They can predict instability. So the most reliable pattern is the pivot shift bone contusion pattern that I showed you earlier. Secondary signs, bone contusion, the PCL can buckle. You can have the deep lateral femoral notch. You can have anterior tibial translation. I'll show you images of all this. You can have an uncovered posterior horn of the lateral meniscus. You can have the lateral collateral ligament entirely visualized on a single coronal image, which is you should never be should be able to see that in a normal setting. And you can have something that is called the posterior PCL line. And in addition, you can also have the shearing injury of the Hoffa pad. So just to go over that, right, to show you. So this is the pivot shift reciprocal osteochondral contusion pattern of injury commonly seen in the ACL injury, where you have edema in the terminal sulcus of the lateral femoral condyle and consequentially as well in the posterolateral corner of the posterolateral tibial plateau. So here you have a subacute ACL tear. You can see now the edema posteriorly is not as much. You have a little bit of diffusion. The ACL has almost like form a little nodule, if you would, or a stump. Basically, you can see how these fibers don't go on; they do not continue onto the femoral condyle. However, you can see the recessed, right, the layering torn fibers more inferiorly. So this is a subacute tear injury, and you can have all the synovitis around the ligament, right, that thickening that we spoke about, the synovialization of the ligament. Can help you detect basically this is not an acute injury. So this is we use something called anterior tibial translation. So normally on the MRI, when the patient get an MRI, you can actually trace lines posteriorly along the femoral condyle and tibial plateau. If that distance is more than 5 millimeters, this is highly specific. It's insensitive, but it's highly specific for an ACL injury. Some people, I use more than 7 millimeters. It's a little more practical, but the literature says that at least 5 millimeters or more is abnormal, and it can tell you that the ACL is torn. This is what we talked about, the buckling of the PCL. The PCL is supposed to be more taut, more straight, but the PCL now is buckled. That's a secondary manifestation that the ACL is torn. There's something called posterior PCL line. So if you trace the posterior margin, a line tangential to the posterior margin of the PCL, and then just basically follow that line, and you trace another line. Basically, this line should be located no more than 5 centimeters from the joint line here. In the case of an ACL injury, this line will not even contact the femoral condyle, and it will obviously be more than 5 centimeters, which is abnormal. It basically tells you that the tibia is too far posteriorly, and hence the PCL is like really buccal posteriorly, giving you that straight up arrow appearance. So if you draw the line from the posterior aspect of the PCL, that should intersect the femur within 5 centimeters from the distal tip, basically. All right, so the deep lateral femoral notch is that impaction injury that you suffer, that the knee suffers, especially in the femoral condyle. What's cool about this is that usually you see a depression in that area of more than 5.5 millimeters, which on X-ray you can actually see that. That's usually how it's catch seen on X-ray first, and then you can say, well, that femoral condyle is too deep, right? That notch is too deep. And if you're lucky enough that you can see a margin, you can measure it. But if it looks abnormal, you definitely should recommend an MRI to further assess the ACL. So the lateral collateral ligament, basically, with a standard imaging plane, you should never see that lateral collateral ligament in one plane. If you do, this is abnormal. So if you have that full visualization of the lateral collateral ligament on the coronal plane, that means that there's a secondary ACL injury. In many cases, a complete tear. This is what when we say uncovered posterior horn of the lateral meniscus, is that tibial plateau should fully cover the posterior aspect of the meniscus, and in this case, it's not, right? So a portion, the most superficial 1/3 aspect of the meniscus it's not covered by tibial plateau. That basically means that the tibia is too far anteriorly, and if you see that on MRI, that's a secondary manifestation of an ACL injury. Sometimes you see shearing injury, right? The Hoffa pad is supposed to be a unified fat plane, basically, but sometimes you can have shearing injury. That's a secondary manifestation of ACL injury as well. You can actually see here complete separation of the free edge, posterior aspect of the Hoffa pad. This is an extensive high-grade shearing injury. So ACL tear can be seen in other fractures such as the Segan fracture of the IT band. You can see basically fractures involving the posterior medial aspect of the knee, the cerebronosis, the posterior lateral involving the arterial ligament complex, or the tibial eminence in young male athletes. So here's an example of a Segan fracture right there. You can see a small little fragment coming off the lateral femoral condyle here with extensive edema, superficial and deep to the bone, and you can see basically how the ACL is completely violated. This is the avulsion of the tibial eminence, right? The ACL coming down, attaching onto the tibial plateau, and you can see the bony fragment avulsed of the native bone here, and that's an example of an avulsive tibial eminence injury. So usually, if you have ACL tear, you can have a meniscal tear. Usually look for the medial meniscus, the peripheral vertical injury. You can have a posterior medial peripheral of the medial meniscus will be violated. You can also have a bulky handle tear as well. You can have MCL injuries as well, and obviously you can have posterior lateral arterial ligament complex injury. And you also always look for articular cartilage damage as well. So this is an example of an ACL tear that has what we'll call a ramp, RAMP. If you look, there's a lot of interest right now in the surgical literature looking at this injury. So basically, this is a peripheral longitudinal tear at the posterior horn of the medial meniscus that can occur in the setting of an ACL tear, right there. So this injury is usually happening in the red meniscal zone, which is the site of impaction during that pivot shift injury that you see that meniscus basically get crushed posteriorly later, presenting itself as a tear in this location. So this is another example of an oblique on the surface flap tear here at the meniscal body. And you can see as we move anteriorly, you can see how the ACL is completely torn. This is actually was a case of a buccal handle tear. This is not only ACL tear, but this is a meniscal fragment that is displaced into the notch, and giving you the classic. I'm sorry, go back here. The classic double PCL sign, right? The flipped medial meniscal fragment will usually be deep to the PCL, giving you an apparent visualization of two PCLs. So aging the ACL tear, I usually don't do it. But if you have a lot of edema and effusion, the injury ought to be acute. But if the edema is resorbed and changes in orientation, right? It's no longer in the posterior synovial recess of the knee. Is somewhere else. They can give you, you can sort of say subacute. I usually don't play this game, but some people do. Remote is usually referred to any injury that has occurred at least by 8 weeks ago. When you can have a completely resorbed ACL, and these fibers can actually fuse to the PCL. I have an image of that to show you. One thing here, right, that a lot of people are not cognizant of is that the meridema can last up to 9 weeks, and hence it's very difficult sometimes to say if it's an acute or subacute injury. I usually just describe what I see. Obviously, if you have history, it becomes a little easier. So this is an example of an subacute ACL tear. You see how the edema now is not as much as the cases that I've shown you so far. You have just minimum fluid, tracking along the ACL. And not only that, the ACL is actually, you have some synovitis back here. And some of these ACL fibers are attaching onto the PCL, which can occur. And commonly I see that as well. This is ACL. Atrophic, I call this an atrophic ACL or completely resolved ACL. The fibers can completely disappear. You don't even have visualization of the fibers anymore. This is a chronic ACL tear with synovialization, right? Synovitis, and the fibers are actually attaching onto the PCL, they fuse onto the PCL. I see that. I see that. I don't see it often, but I see it enough that I'm very careful how I describe it on my report. So partial ACL injury, sometimes it's difficult to differentiate from complete tear. We have so much edema there that it's quite difficult. You can say, I usually say a near full thickness to full thickness ACL tear. If I'm not sure, I use that terminology, and then I say correlate with clinical exam to assess the degree of instability. And basically, the MR differentiation is, to me, is of an academic interest. Because if you describe a high-grade ACL tear, the surgeons, in the physical exam sees high instability, that person will go on to have a ACL repair no matter what. So just diving into the anatomy of the ACL a little bit more, you have the anterior medial fibers, you have the posterior lateral fibers, and MRI, you can distinguish one from the other. Here's the anterior medial, posterior lateral fibers. And then on the axial plane, basically, you will see, here's the ACL. You will see the respective bundles, basically, and how they look like. So here's the most distal plane here. You have the PCL, you have the ACL. But again, I just describe what it is. Sometimes I just say, predominantly center in anterior medial aspect of the ACL, or predominantly center in the posterior aspect of the ACL. Here in the United States, most likely it doesn't matter what the injury is. If it is more than 75% and the patient is unstable, the ACL will be repaired no matter what, right? So again, the anterior medial versus the posterior lateral bundle, you can see different, MRIs here. Showing you the anterior medial here, bundle, the posterior medial bundle. Anterior medial will always be anteriorly here, and then posterior medial bundle. Again, if the anterior medial bundle is commonly torn, if it is torn, it's likely an unstable injury. So this is perhaps a subacute injury, right? With synovialization of the ACL and a high-grade tear and injury. This is a synovialization, in the setting of mucoid degeneration. So when you get that thickened appearance of the ACL, that can happen over time. Sometimes previous injury, I've seen this in younger patients and older patients. So what you see is just thickening of the ACL. There's no mention of any trauma, in the acute setting. And you have thickening of the ACL and lack of normal fiber anatomy. So that's mucodegeneration with ACL synovialization, meaning that because the ACL is an intraarticular synovial structure, so the synovium layer that normally exists around the ACL gets very thick and gives you that thickened, blurry-like appearance in the setting of mucodegeneration. So here's another case of that. You can see how the ACL looks quite irregular here, thickening. You can also get the ganglion cyst as well. I see that very common too in the setting of mucodegeneration. So PCL injuries are less common. Moving on to the PCL, less common than ACL. This is a very strong ligament. Only roughly 30% of PCL injuries are isolated. Usually, most of them are encountered in the setting of multiple injuries. It's difficult clinical and arthroscopic diagnosis. MRI plays a pivotal role here. You can see a PCL now that is buccal in the central aspect of the structure with complete dissociation of the fibers, but almost near complete to complete dissociation of fibers. Look for other signs of PCL injury. So usually this is a dashboard. We call it dashboard injury, where the knee is slightly flexed and you get impacted in the anterior aspect of the knee with edema superficial to the patellar tendon, and you can get the contusion pattern in the anterior aspect of the tibial plateau. And then as the femur, as the tibia is driven posteriorly, it tears at a PCL ligament. Usually isolated is only seen in 30%. You see it in combination of other injuries as shown here. So the way it works is basically get a direct blow of the knee where the knee is slightly bent. It's classically called a dashboard injury. You get posterior translation of the tibia, and most commonly, this is the most common type of injury that affects the PCL. Other injury patterns you see that with is hypertension injury, usually in the setting of sports-related activities. Rarely you see it in isolated to the PCL, and you can also see it in the setting of the knee dislocations. So usually you're going to have a mid-substance interstitial tear, most commonly presenting as a focal area of enlargement that will be high on T1 and T2, higher sin intensity than the ECL in any sequence, right? That's a good trick that you can use to detect injury within this ligament. You can have complete tears that show a disruption of the ligament. You can also have avulsion of the tibial attachment. So here's a PCL that on T1 is thickening. It's not dark signal the way it's supposed to be. And then on the T2 side, you can see basically a high-grade partial thickness tear of that ligament there. Here's the Humphrey ligament sign, right? Sometimes you can see the Humphrey ligament completely, separated from the PCL, and it can help you detect basically the injury to the PCL itself. Sequela of PCL injury, you can have premature medial and patellofemoral OA. You can have weaker association with the meniscal tears and ACL. Better prognosis than ACL for sure for to return to sports activity. Usually in the chronic setting, you see a thick ligament. That basically means that the interstitial tears are healed. You will see low sin on T1 and T2, and you have a regular or undulated appearance. So here's an example of a chronic ebullitive injury of the PCL. You can see how the mid and distal aspect of the fibers are thickened, but not only that, you have a bony fragment that came off of that posterior attachment onto the tibia. The classic mechanism of injury of PCL injury is hyperextension. You can have gastrocnemius tear. You can have the classic bone bruise Potter, which will be in the anterior femur, anterior tibia classically. So this is the hyperextension marrow edema with reciprocal edema onto the femur and the adjacent tibial plateau on the anterior compartment that blows up the PCL posteriorly. This is a classic hypertension injury right anteriorly onto both the medial and the lateral compartments, involving the femoral condyle and the tibial plateau as well. Here's a PCL completely violated here. All right, so moving on, the posterior lateral corner, the dark side of the knee. I tried to go a little faster here because I'm running out of time. Very complex, variable anatomy. And not widely recognized bone marrow edema pattern that can tell you that you have a posterior lateral corner injury. Leg here, you will have an external rotated limb because the posterior lateral corner is completely violated, and it doesn't restrict that internal, inversion, basically, if you would, of the limb normally. So you're looking basically for fractures in the Gordis tubercle, Segan fractures. On MRI, you want to describe the severity of muscle injury, the extent of ligamentous injury, whether or not you have a hematoma, associated meniscal tears. You can have classically early OA in that compartment as a result of instability posterolaterally. And you can have basically other things like impending ACL graft failure as a consequence of injury in this compartment. Basically, the anatomy is quite complex. You have multiple players here. The popliteus tendon, the lateral collateral ligament here, and the acral ligaments are classic players or components of this compartment. The layer one basically will have, I just wanted to make sure that you know of the common peroneal nerve that can classically get injury. It's located between the deep and posterior to the biceps at the level of the femur. So on MRI, just lay eyes on the common femoral nerve, which can get injury during this, in an injury that involves posterior lateral corner injury. Again, multiple players here, right? So you have the acromion ligament here. You have a lot of lateral collateral ligament injury. You can have an acromion ligament injury as well. So this is just the different components of that compartment, which is quite complex. So here you have the acromion ligaments, you have the palliative tendon coming in, you have the palliative fibular ligament here, and you have the fibular ligament in addition to the lateral ligament. Quite complex, many players involved in this compartment. So here we go again, right? The acromion ligament is a very thin layer that usually have a Y shape. Medial and lateral length, right? Medially and laterally as well, that plays a pivotal role in the posterior lateral corner anatomy. So different players here. This is the lateral collateral ligament and the palliative ligament. So this is the palliative tendon coming in, and it sends a little extension here known as the posterior fibular ligament, which is classically injured and involving an injury in this compartment. So in addition to that, you can have, this is the different settings. You can see gun fracture here with basically an ACL injury, and then you can see concomitant injury at the posterior medial capsule with edema posteriorly. All right, so this one is a palliative tendon strain. Palliative is a window to the posterior lateral corner on MRI. Basically, it's the way that you get access to the joint. These are different injuries involving the acromion and palliative fibular ligament. So you can see the palliative tendon and muscle coming through. You don't recognize an extension here. The posterior fibular ligament has been completely torn in this case. This is an example of a hyperextension injury with a classic contusion anteriorly. And then you can see the lateral collateral ligament completely torn. Completely torn with extensive edema deep and superficial to that ligament. You see the biceps tendon is also torn as well. And the IT band is completely dissociated and evolved proximally as well. But sometimes this injury can happen as a non-contact injury. This is a quarterback that presented with this injury where the palliative muscle was completely torn and recessing posteriorly with a lot of extensive edema posteriorly. So you can have it as a non-contact injury. Usually it's a contact injury, but you can have it in this setting as well. This patient also have an intact palliative fibular ligament. You can see it over here. Even though the muscle is recessed, but distally you can still. He had an intact ligament back here. This is another example of a college soccer player presenting after a twisting injury with extensive muscle edema and ligamentous injury posteriorly. This is a palliative strain. However, the palliative fibula and the acromion ligaments are completely gone and dissociated here. This is a highly unstable injury, and you should report basically the specific injuries. And sometimes I even call the surgeon and say, this is there's so many structures here injured that you ought to consider this to be unstable. I usually say, correlate with clinical exam. This is an NFL that presented with an ACL injury. And then you can see the extensive injury along the posterior lateral corner of here. The palliative fibular ligament is completely torn, and posterior laterally he was quite unstable. This is a radial injury with extensive. I mean, this is complete dissociation the posterior lateral corner here. However, he not only had that, he had a vascular injury. This is a catheter-based angiogram, and he had complete tibial trunk transection as a result of this injury. Let me just go back one more time here because I think I'm going too fast. Basically, this is a T2 facet image here. The artery should have a black dot, right? Should be no signal here. However, everything is bright back here, telling you that there's a thrombus in that on that tibial peroneal trunk, which was completely transected. The concept of multiligamentous knee injuries, right? This is if you see more than one compartment that is violated and the ligaments are torn. I won't go too much into this, but basically if you have multiple injuries involving multiple ligaments, ACL is torn, PCL is torn, the posterior medial corner is torn, you have to say that this is a highly unstable injury and there's a high probability of vascular injury as well, it is your role to say that. And then they can, basically, vascular surgeon can correlate clinically. A lot of times that ensues a CTA, a CT angiogram, looking for vascular injuries. You can see how this person has multi-ligamentous knee injuries with basically vascular injury detected on clinical exam and also CT angiogram as well. Mechanism can sometimes be difficult by MRI because you have so much edema everywhere. You don't know what it is. So I usually say, well, if it's classically isolated to one compartment, I will say hyperextension mechanism of injury. But in the case of so much edema, I just describe what I see basically. And in my report, in the impression, I say medial compartment of the knee, demonstrate the following injuries. I say MCL grade 2, and I kind of like break it down into different compartments. I say, medial compartment, here are the injuries, lateral compartment, here are the injuries, posterior compartment, here are the injuries, and then let the surgeon decide what sequence of he's going to take to repair that knee. In the setting of dislocation, anterior is more common than posteriorly. Posterior dislocation requires a greater force of impact. Vascular injuries are more commonly seen with posterior dislocation. Extensive mechanism of injury are more common with posterior dislocation, and usually the lateral compartment is mostly affected, and then the medial, and then you have the combination, rotatory combination, common last year at 4%. This is a dislocation with vascular thrombosis. You can see the complete violation of the ACL, and however, you can see how the back here the actual tibial trunk is full with a thrombus, basically. MRI after cruciate ligament. I don't know if I still have a lot of time, but I can just quickly go through this here. What are the things that can happen wrong with the graft placement, right? So this is a femoral tunnel that you can see. Let me go back here one more time. Do I have more time or? Hello?
Yes. Please go ahead, and
Okay.
we can spend more time here.
Okay. So I'll go back here. So basically, I think I put this here just because a lot of the athletes undergo ACL repair, right? So what the surgeon needs to know, they need to know the status of the graft, whether it's intact. If you have a lax knee with disrupted or stretched fibers, and then if you have any evidence of impingement, arthrofibrosis or cyclops lesion, if you have any loose bodies, or if you have any other secondary manifestation of internal derangement. The other thing that we look at is the status of the tunnel, the position, whether or not you have any osteolysis or presence of a ganglion cyst. Always look at the status of the hardware, position, and integrity, and any other associated pathology in the meniscus and cartilage for being the most relevant sites that you want to look additionally. So this is my algorithm that I use. Determine the graft substrate if possible. Sometimes you can see, bone patella bone autograft. Sometimes you can see hamstring autograft, allograft. Sometimes I try to do that. Sometimes it's impossible, but I tried. I look at the graft position. I look at the status of the graft and hardware, and then any other associated pathology. So the consequences of suboptimal graft placement will lead to limitation of joint motion, constraint joint motion as well, because you have compressive loads on articular cartilage that will lead to OA. You can have fixation site failure. I see that commonly sometimes. You can have graft dispersion and hence leading to patholaxity, and you can have graft failure or complete rupture. So here's the femoral tunnel. You can see the screw right here that is completely out of the tunnel, completely, the biocerebral screw is completely dislocated and dislodged outside of that tunnel, and hence the ACL graft is completely resolved and torn. There's a concept of ACL graft impingement that I added an image here for you to see what that means. It usually means that there's an anterior displacement of the tibial tunnel, right? The anterior tunnel way too anteriorly. That graft gets crushed, and because it gets impacted at the level of the roof of the intercostal notch, especially during the extension of the knee. And the way you will see is non-undulated ACL fibers that is having a hard time getting to the tunnel because the tibial tunnel is way too anteriorly, and that fibers get crushed with the notch here and just impinging the graft over time, leading to complete tear and failure. you can see sometimes what happens, you get osteophyte that form at the notch level, the roof of the notch, completely crushing those ACL graft fibers that over time will lead to OA arthritis, right? Meniscal pathology, and also complete failure of the graft. Usually, the tibial tunnel is too anteriorly. If you have a graft failure, it occurs on terminal extension, right at the very end of extension, and it's very hard to assess arthroscopically, and hence the MRI plays a pivotal role to determine, to tell the surgeon what the problems are. So basically, when you're looking at an MRI, you're looking at the graft is angled over the edge of the intercondylar roof. You can see increased tendon intensity within portions of the graft, especially distally. That's the area of contact, right, where the graft is getting crushed and damaged. And usually it's evident about at least 3 months after surgery, and then can resolve after 3 months following correction as well. So here's an example of an ACL graft impingement. You see how the anterior tunnel is way too anteriorly. The fibers take this undulated, right, wavy-like appearance because they're having a hard time getting to the tunnel. You can see osteophyte at the roof of the notch that form. And this osteophyte is basically literally jabs that those traversing fibers leading to complete graft failure. Here's the basically sometime in the future with you can see how the pattern of ACL graft takes that wavy-like appearance instead of being taut and straight in one line. Takes a little wavy appearance because the graft is being impinged over time, which leads to degeneration and complete tear. So there's something called a stiff knee, right? Sometimes the surgeon wants to know whether or not there's arthrofibrosis. Usually it will be located anterior to the ACL fibers. You will have a focal scar that will be dark on T1 and T2 and limits full extension of the knee, and the patients present with anterior knee pain. Arthrofibrosis is usually seen or clinically in with limited terminal extension, and they tend to be localized anteriorly. And there's no differences in size of intercondylar notches, so hence it's difficult to say, well, the larger lesion will lead to, are associated with more issues. Usually what I do is like I see it there, I just describe it and let it be. The surgeon will take it from there. This is an example of a smaller lesion here size, very tiny here, and this is another knee that's showing the very large ACL anterior to the ACL cyclops lesion. One thing that I have to say is there's literature out there that says that cyclops lesion may be has been usually described after ACL graft repair. However, it can be a result of a partial ACL tear. You can have a partial ACL tear by itself with a cyclops lesion. It's not unique to the post ACL graft reconstruction state, basically. Large cyclops lesion here, look huge, right? And then here's another recess here, nearly occupying the entire space here. This patient presented with very limited extension of the knee, and the cyclops lesion dates back to the painting, right, by Redon in the 1900s. The stiff knee is usually it's a notch impingement after fibrosis. You have the impingement basically will lead to fibrosis productive change, and hence you ought to look for that osteophyte that forms at the notch of the roof of the notch. What they do to fix that is they do naturoplasty, where they actually carve all that osteophyte off the bone to prevent future problems. And then again, you're looking for a proliferation over time for the graft angle over the edge of the intercondylar notch, and then always look at the roof of the condylar notch to osteophytes in that location. And I just describe the findings basically. So here's an example of an NFL quarterback after ACL reconstruction with an audible PAP or knee extension again, right? So what do we have is the date of injury here, and 20 months later, right? This is a mess basically. You have the distal fibers here completely avulsed off the tibial attachment. You have a large osteophyte here, impingement. This is synovitis. This is a complete disaster basically. And on T1 you can see actually the arthrofibrosis as well within the anterior knee compartment. Always look at the status of the tunnel. right? So whether or not there's a normal widening. Some people, there's literature out there that says that usually the tonal should be no wider than 1.5 centimeter. There's a gray zone between 1.5 and 1.9 centimeter, especially anything greater than 2 centimeter is abnormal. And that if they want to fix that, basically you have to have a two-stage procedure where they graft that hole first, that tunnel first, let it heal, and then the patient goes back for the actual ACL reconstruction. So the first 3 months after a graft is placed, it can happen. The etiology is probably immunologically related. There's a high incidence of graft failure with motion and stretching, and it will require a two-step graft remission. So I always measure the size of the tunnel, and if it is definitely more than 2 centimeters are normal. It's too wide. If it's between 15 and 1.5 and 2 centimeter in that gray zone, I describe it, and it says is on the upper high normal limits of normal, and then the surgeon will have to determine if he needs a two-stage repair procedure. So the tonal expansion, the pathophysiology is unknown. Some people think that it's because you have a windshield wiper effect, the bungee cord effect, right? Kind of like the fibers are not completely attached to the bone, and hence you have micro motion, and you can have some synovitis and granulomatous response in that space, leading to vasculitis and resorption. Here's a tonal expansion. Look at the tibial tonal, right? Huge, and a lot of fluid. Ganglion cysts, those fibers are not even attached anymore. A lot of them are actually evolved, and they are recessing within the anterior compartment here, anterior synovial recess. This actually distracted fibers with now arthrofibrosis, right? Cyclops lesion. But this is a highly unstable graft. You can have impingement. You can see the undulated appearance of the graft fibers here with impingement. Here's a femoral tonal expansion, right? This is very large here. This is a tibial tonal expansion in the setting of PCL reconstruction complication. So basically, there's very little about that in the setting of PCL, but look for similar pathology as the ACL failures, loosening degeneration, arthrofibrosis posteriorly, and in concomitant meniscal tears and injuries. So overall, right, knee ligament MRI in 2022 determine the mechanism of injury is key to understanding the full extent of the injury. Using marrow contusion patterns in isolation can help you determine if you have an ACL, an MCL, or a PCL injury. Pivot shift usually means ACL insufficiency, right? Watch out for the isolated PCL tear. Recognize posterior. You ought to spend a lot of some time understanding the anatomy, especially in the posterior medial and posterior lateral corners, for you to describe the injuries properly to the surgeon. Recognize that when you have multiligamentous knee injury patterns, edema everywhere, right? And then the association of that to vascular injuries. Always put that in your report, right? Multiligamentous injury, vascular injury, highly associated. And identified MR findings suggesting a malfunctioning ACL reconstruction graft. Look for impingement in the roof, bone formation and osteophyte there, the expansion of the tonals, right, and in presence or absence of arthrofibrosis. So always look, methodologically, create an algorithm of search that you have, and then you describe that in your report. All right, with that, I end my presentation. Thank you so much for your time. I know this is a lot of material to cover, but I thank this platform to allow me to have enough time to go over it. So with that, I'm open to questions.
So thank you very much for very impressive presentation from Dr. Gonzalez. So before we end it, we have some question from audience. So they need could you explain about meniscocapsular separation and posteromedial sprain with or without meniscal tear?
Yeah, that's a really good question. So, and I could go back here. So basically, I give you my personal opinion. So I'm sure there's debate out there. There's a lot of debate on the literature about this, right? So basically, for me, meniscal capsular injury is when, let me just go back here so you can find the, so posterior medial capsular injury is when you only have the ligaments are torn. So you will have basically a situation where, you can see here, let me see, I think I have a better, so you will have a situation, here it is. So just to, just to show you this, perhaps if we have it next to each other, you see a little bit better. So basically you have, right, so, this ligament here, you can see, right? So this ligament here is the OPL, right? And this ligament here is the POL, right? Don't worry too much about the names. Sometimes if I don't remember these names, I just say, I would say posterior medial capsular ligaments, right? So basically, if I just see the edema and the disruption of normal anatomy limited to those ligaments, I call it a meniscal capsular separation injury. But I describe it, right? I say, edema with thickening along the posterior medial capsular ligaments, not involving the adjacent surface of the meniscus. Some people believe that if you have meniscal capsular injury, you inherently will have, even at the microscopic level, you will have some injury of the red meniscal zone of the adjacent meniscus, posterior horn and medial meniscus. So I heard, in meetings, people say that if I see a meniscal capsular injury, I call it, I would say peripheral longitudinal injury as well of the meniscus. For me, is if I see edema limited to these ligaments here, just by itself, basically, the edema will be just here, right, in this compartment here, without affecting the anatomy of the meniscus. I call it meniscal capsular separation injury. But if I see basically any even the slightest sign that the red zone of the meniscus is torn and violated, I would say meniscal capsular injury / peripheral longitudinal vertical tear injury of the adjacent meniscus. And I will say, period, correlate clinically. So I think that, that's my take on it, basically. I don't know if I answered the question, but so the posterior medial corner injury will be when those ligaments are torn, right? The posterior medial and posterior central aspect of the knee is edematous, and the edema involves those ligaments, the posterior oblique and the oblique popliteal ligaments of the joint capsule. That's the posterior medial, the classification of posterior medial corner injury.
Okay, thank you. And there is another question. Can cyclop lesion occur without ACL graft?
Yes, 100%. So just look it up, right? Look, once unfortunately, I forgot to add those publications. So look up cyclops arthrofibrosis in the setting of ACL and PCL tears, native PCL and ACL tears. It has been described in the literature, plenty of it. So it's not unique to ACL graft reconstruction.
I have a question. Just a very short question, but about the protocol, about the treatment, and about the report. For the protocol, you prefer 1.5 or 3 Tesla for MRI of the knee?
I think that, in my humble opinion, I think 1.5 does a decent job. Again, it depends, who you're serving. So the places where I practice, I practice at Emory University for a few years, 5 to 6 years. There, we reserve the 3 Tesla to the professional athletes, just because they feel that they just getting higher resolution MRI. In my opinion, right, for these injuries, 1.5 is good enough. You do not necessarily need a 3 Tesla. However, if you have an elite, if you're serving an elite sport team, and then traditionally here in the U.S., those patients are imaged at 3 Tesla.
Okay.
Yeah.
Any particular pulse sequences or the plane that you need, or it's just a routine or regular plane and sequence?
Usually I just I'm used to the regular plane. I know that some institutions have instituted the oblique ACL plane, right, where they see the ACL profile. In my opinion, if you look on the axis, if you look on the chrono, using standard imaging is enough. There's a research here in the United States where they want to go to a 5 minutes protocol with accelerated imaging. Look up research from Chabran from Texas, and the I forgot the name, the other guy, the other person. He's from Cleveland Clinic. So the 5-minute protocol with similar resolution and detection of injuries. But for me, just a standard protocol without any additional imaging, I can tell you most of the injuries are based on that.
How long does it take to image the whole set of these images for knee injury?
30 minutes usually,
About
25
30.
to 30 minutes.
Okay. Next question is about the treatment. Is there any like a specific time that you should intervene before further damage on the joint?
Yeah. So I mean, I'm not a surgeon by any means. So if there are surgeons, colleagues in on this call, I'll probably refer to them. But I heard, for example, the MCL. Usually, you should fix them within 3 months after the injury. It doesn't have to happen right away. Actually, the ACL injuries are not repaired immediately. They actually go through physical therapy first to surgically repair these. I reserve that to the local surgeons. They're more in tune with the most common practices.
As a MSK interventional radiologist, is there any role of intervention about that you can do for this knee injury?
Yeah, I mean, again, in the acute setting, perhaps the surgeon can ask you to evacuate a hematoma, right? To go put a needle in the hematoma collection and draw that. Usually, the roles that I've seen is in the more late phase. Once the repairs have taken place, if the patient's still having pain, then you can intervene. So you can do things like, for example, genicular nerve blocks or ablation. You can do things like PRP injection, targeting different structures. Sometimes, cortisone injections also will help as well. But those will take place more in the late phase after the surgical procedure have taken place and the patient still having pain.
I see. About the report, I have no questions about the post-op, but in the pre-op, do you have any standard template that we can use?
Yeah, so I can send you. I know there's so many templates out there. I can definitely make my template available to you through you, perhaps, Sil, if you want, and then you can just send it to everyone that participated in this talk today. I can definitely make my templates available for distribution if you want.
Thank you. Thank you.
Okay, I don't think that we have question from the floor from the participants, but anyhow, it's very impressive and very detailed. So we have to thank Dr. Gonzalez that gave very impressive presentation, even a little bit long over time, but still this is very quite clear and very impressive for our audience. So I will refer to Dr. Silanat. So we go on to the last session.
Yeah, thank you. Thank you so much, Dr. Gonzalez. That is a lot of work. A lot. Like for me, it's going to take months to get that talk done. Thank you.
You're welcome. You're welcome.
And I want to emphasize again about our next session. It will be a hot topic and cutting edge topics in radiology. We'll start with the utilities of dual energy CT in cardiac imaging by Dr. DiCecco from Emory on Sunday evening, Asian time, the 10th of September. I will send out the newsletter this week. So keep your eyes on your email. So it will be in your email, all of the detail of this program for the hot topics.
Pardon me, Dr. Silanat, it's not Saturday evening.
Yes, we change from Sunday to Saturday because of the speaker, they want it on Saturday.
Yes, so Saturday evening, not Sunday, right?
Yes, not Sunday, yes.
Okay. Yeah. Thank you. So I think we close the session.
Yes.
Yes, thank you everybody. See
Thank
you.
you.
And
thank you. Enjoy.
Bye.